My name is Manda. I'm part of the Community Council as well as a parent of a child with CP. And next we will be doing about choosing an intervention. And I'll just explain the session a little bit first, and then I'll introduce our speaker. So the session this morning, we will be providing an overview on guiding principles on various therapies for cerebral palsy. Specifically, it'll include such themes as the natural history of patients with CP, the ICF model and the F words approach, as well as the level of evidence of various interventions. It is my honor and pleasure to introduce Dr. Ronit Mesterman, who our family has had the privilege of knowing her for many years, and she's actually our neurologist. So Dr. Mesterman is an associate professor of pediatrics at McMaster University in Hamilton, Ontario, Canada. She is certified in pediatric neurology and developmental pediatrics. She joined the faculty at McMaster University in 2004. Her dual training reflects her philosophy that developmental pediatrics and child neurology go hand in hand, and as such, she is working clinically in both divisions. Her main clinical and research interests are the assessment and treatment of cerebral palsy. She established a very busy multidisciplinary spasticity clinic at McMaster. She's a member of the executive committee of CPNet, a research-based initiative designed to improve the care of children with cerebral palsy and their prevention to treatment in Ontario, Canada. Dr. Mesterman?
Okay.
Thank you.
Do you hear me? Yeah. Okay. Okay. Thank you, Manda, for the introduction, and thank you for the organizing committee to invite me. I really feel honored to have this place. So Manda actually asked me, what do you want to talk about? And I really have a passion about counseling families, and so I picked this theme because I liked to go back to the literature and make sure that I'm actually counseling my patients in the right way. And I'm happy to take lots of questions at the, what did I do? Okay, good. So ambitious talk, and I will say in advance that I will not be able to go into details of specific interventions. There are way too many, and each of them would be a separate, so it's really more of an approach talk. So I will start basic because I wasn't sure who is in the audience, and I want to start with definitions of cerebral palsy and the classification, overview of the associated problems that also might need treatment, and then touch on frameworks and general principles that stand out for the interventions that we have evidence that are working. Okay. So again, why did I feel that this is a topic that is worth reviewing for myself and presenting to you is when we look at the evidence and the publication numbers in research. So when I go in and want to know what's the latest in something, I use a website that's called PubMed. There are other platforms that people can use as well, and PubMed is my go-to place for any up-to-date research. And when you look at the graph here, so when I entered search terms of interventions in CP, so very broad, I got for the last 60 years, 1964 to 2024, a total of 59,262 publications. But then if you look at the graph, it's very obvious that there is a steep incline. So for many, many years it was very flat and there wasn't a lot of new research. And now it's happening, finally. And it's really good that it's happening. And so in the last 5 years alone, out of the 60,000 papers, 24 were published only in the last 5 years, and almost 40,000. So 60% of the public data is only from the last 10 years, and 50 years before was very little, right? And so it is daunting for all of us, the families, but believe me, also for us healthcare providers to stay on top of that amount of data. Because if you think about it, it's 5,000 publications per year. How do you even read and digest and know what's really worth it? So, again, I like to start basic, and I do this in all of my talks, also to my residents and also to my professional colleagues. It puts you back into what are we actually talking. So again, I picked to focus on cerebral palsy, and it is an umbrella term, right? It's a group, it's not one single condition, it's a group of conditions that have a permanent disorder of the development of movement and posture, causing activity limitation that are attributed to a non-progressive disturbance that occurred in the developing fetal or infant brain. And yesterday morning we had this amazing discussion around, do we actually need a new diagnosis? So I like to just summarize this very first sentence, and it reminds me always the language of lawyers, right? Every word has a meaning and has a place of interpretation. But to simplify it, we're talking here about a group of conditions where something went wrong in the developing brain, so it's brain-based here, but it affects the body. And in 2007, when the last time the definition was revised, the main driver behind that was that people felt that there was an overfocus in looking only at the motor disability, and that CP in the end is so much more than a motor disability, and that's where esteemed colleagues felt we need to add in a definition the associated problems, which is actually not the core symptoms of CP, but to just remind us. So the second sentence, which was the new thing on the definition, was that the motor disorders of CP are often accompanied by disturbances of sensation, perception, cognition, communication, and behavior, by epilepsy and by secondary musculoskeletal problems. And again, I want to just quickly put it out, because when we talk about interventions for CP, are we talking about the interventions that are targeting the first sentence, and are we targeting the second sentence? And of course, my answer is, as a holistic thinking physician, you have to target both, right? It's not either or. So because cerebral palsy is really an umbrella term, and it's a wide spectrum, we have subclassification to make justice for the variable phenotypes. And again, a quick overview. So over the years, different subtype classification have attempted, and some have stayed around and some have come and gone. So right now we actually subclassify in 3 big categories. First of all, we talk about the type. So the type, and again, every 10, 20 years we are reclassifying, but as of now still, we're using 3 subclassification for the type, which is spastic, which is our predominant presentation, dyskinetic, and ataxia. So that's how the muscles feel when we examine them. Then the second subclassification is what we call the topographic, which part of the body is affected. And that gets classified in either unilateral, one side, which we call hemiplegic, or the bilateral affected, which is either the diplegia, which is the predominantly leg domineering problem, or quadriplegia, where it affects 4 limbs. And I will mention there's a bit of a difference now between North America that uses this separation between diplegia and quadriplegia. When you read literature from Europe, you will be more coming across the unilateral and the bilateral. And as a neurologist, I will say that those 2 types, the type and the topographic, are very much tied into the pattern of distribution of your brain abnormality. I'm staying away of the word injury, because we're not only talking about injury patterns. We also include genetic abnormalities that make your brain form differently. So again, when I talk about principles of intervention, it is important to recognize that based on your anatomy, we might have different pathways. And then the third subclassification, actually, pour me some water, thank you, is the functional classification. So regardless of what anatomy is affected, we just look at the child's movement and we decide where in the spectrum are you functioning. And that is the GMFCS. I'm of course very proud to share that classification because it is originating from McMaster Children's Hospital, specifically from CanChild. So it is a 5-level classification level 1 being the most functional, where the children are able to walk and run. And then on the other spectrum, level 5 would be the children that are wheelchair dependent. Now this illustration, which came from the Australian group that are big leaders in CP research and publications, is really the picture that highlights how children look or function in the various GMFCS level when they're age 6 and above. So nobody would be classified as a level 1 at age 1, because we're not expecting a child with CP at age 1 to walk, but we have descriptors on how those children function when they're young, and we can actually predict that you fit the category of a level 1 or a level 3 going forward. And for those who are interested, there are beautiful videos on the CanChild website to be able to actually learn more about it, but also to identify. We have done good research to show that parents are very, very accurate in picking for their child the right functional level. And reason why I'm bringing this up is you will hear me talk a little bit more when I go into general themes of interventions and specific interventions, that a lot of them are talking about which interventions fits which type or which topographic, but also very much linking it to GMFCS. So when you have a discussion about what is the right intervention for my child, you need to be familiar with that. And that's already one of the problems, that often I get referrals of patients, even at an older stage, and nobody has even introduced the discussion of that functional level, which is so important to setting the right level of understanding what might be a fit. So reminding you, in the division, we talked about the associated medical problems. And again, the neurologist in me wants to really highlight that the brain, which is in CP the place where the problem started, is the command center of our body. And so you can imagine that when you have brain changes, it will affect almost every function in your body. Not all, but almost all. And it varies depending how much changes you have in the brain and where your changes are. So some areas in the brain are very clear mapped. Just as an example, vision, so you have the eyes, but in cerebral palsy, the problem is often also in the eye, but more often in the brain, and the brain is the yellow area here in the back. That's why I painted it yellow. But you have other areas in the brain that are more everywhere feeds in. So for example, cognition is much more difficult. It's not one plate, it's much more sophisticated. So I don't have a brain space where I see the lesion and I can tell you for sure you will have a problem, but we do have correlations. So again, just to walk you through one more time, the associated problems, you have the group of musculoskeletal problems, including bone health, osteopenia, hip, and there are more. I just gave a few examples. Then you have sort of the emotional, cognitive, and I included here the epilepsy because, again, it doesn't sit in one brain space alone, which are very much associated with CP and very much often goes hand in hand with GMFCS level. We talked already about vision, hearing. We just heard from Dr. Golda Milo mention that sleep is very prevalent, and pain, unfortunately, too, and it's a topic that we are getting more and more aware. And then the GI, the gastrointestinal tract, I like to say, starting from the mouth to the other end. And again, being aware that those associated problems happen in a high percentage. I on purpose did not put the percentages in here because it varies a lot by type and GMFCS level. So epilepsy, for example, could be 20 to 80%. So for the individual, it is important to then recognize my specific child has a chance of maybe on the 20%, or if you have a certain lesion, I can tell them, sorry, your child is more likely to be on the side of 50 to 80%. Okay, so CP used to be defined as a childhood disorder, but it definitely is a disorder that starts in childhood. But it's a lifelong journey, and we're happy to say that longevity is becoming more and more the reality. And so the journey has ups and downs like life for most of us, and sometimes it has a turn and we don't see around the corner what is coming next. And sometimes it's exciting and sometimes it's nerve-wracking. And again, there isn't a plan of do this on day one and do this on day after 2 years, but we have ideas what might work and what you could consider. And so again, coming from a medical model, so in the 19th century, antibiotics were invented, immunizations were invented, so the concept of prevention, but also finding a cure for a bug that is identified and you're healed, was driving medicine for many, many years and is still driving. And ideally, we want to cure people if they have a disorder. But we know, unfortunately, as of now, cerebral palsy does not have a curative treatment. And therefore, our goals for treatment should include best possible function, ensure the best level of activity and participation, reduce pain, and really make sure that we have a healthy life. And to acknowledge that challenge that we don't have an easy cure, the World Health Organization in 2001, which is almost now 25 years ago, decided to have a framework. So this is not a design just for CP, it's designed for also adults that had a stroke, so for neurodevelopmental disabilities in the broader sense. So ICF stands for International Classification of Functioning, Disability and Health. And in these days, we really do not speak about treatment of cerebral palsy without thinking ICF, or we shouldn't do anything without thinking that. So in our biomedical model, really we have the health condition, and the body structure and function is what we used to target, and we still target it to some extent, but what is now different in this model is that we really look into how does it interact with activity and participation. Our goal is really to not just change the body with the idea that that's what you have to do. So as an example, if we have a child with spasticity and we look at them and they look very stiff and they cannot move, it often makes people feel, oh, can we just reduce the tone and then everything will be fine? But unfortunately, that's not necessarily the case. And so we still might need to intervene with the tone, but really the whole goal of this now is not just to show that the tone is lower, but we want to really understand how does it affect, hopefully positive, the activity level and participation. In addition, in the ICF model, we also take into account environmental factors and personal factors. So what is it that the child brings to the table? What is the child wanting to do? And sometimes we want them to be active and participate, but the child might be an anxious child, and actually us pushing them into that direction might create more anxiety and might not be the right thing, and vice versa. A big one is the environmental factors. We have learned that by adjusting the environment, we can often create more chances and possibilities of activity and participation. So the trick is we don't always have to fix the child, but let's fix the environment, or fix is maybe not the right word, but adapt the environment or provide the child with right technology so that they are able to have the activity and participation. So again, this is a framework, and for many years, in many different conditions, we're using that. And then, in 2011, my esteemed colleagues, Dr. Peter Rosenbaum and Dr. Gotha, both active member at McMaster and CanChild. Dr. Rosenbaum was the founder of CanChild actually 35 years ago. And they had a bit of a provocative publication about the F words. And of course, everyone thinks about a specific F words, but no, our F words are function, family, fitness, friends, fun, and future. And so what this effort, approach, or philosophy is really about is to say, okay, we have the ICF, it's a bit theoretical, how in day-to-day life, what does it mean? And so they've used those domains and mapped them onto the ICF. And now the body structure is becoming fitness, the activity is the functioning, the participation is really all about friends, environment becomes your family, and personal factors are fun, and then future is just everything together. And again, it's a philosophy, and it invites all of us to really rethink how we deliver services. And I'll go back in some of my examples to that philosophy. Okay, so the first slide I opened was the graph with all the thousands of publications. And another esteemed colleague of us, Dr. Iona Novak from Australia, has really taken on looking at evidence of interventions and services. And she created what we call the traffic light system. So she published actually several papers around 2013 and 14 around this theme. And I'll just skip here. It's one page, one graph of many of these in the paper, where she has taken published papers and analyzed them for their quality and for the indication of does it work and does it not work. So she had very clear guidelines, what is regarded as good methodology, and ranked them. And she looked at what are we using intervention for. Because a big thing is, a long time ago, there was very generalized approach of, oh, you have CP, so you go to physio. And it wasn't clear what you're actually training the patient about. So now the papers, also when we publish now, it's very, you have to really label what you're treating. You can't just say, I'm treating CP. You need to say, I'm treating, I want to improve the tone. I want to improve gait, posture, contracture. So each of these columns has a title. It's very fine print. You might not be able to read it. And I don't want to go into too much details because then you get lost. But just to give you an idea, the first column here is about spasticity management. And so the green bubbles stand for papers that showed evidence that it's working. So people have done research and published data and shown results that there is a clear effectiveness. The size of the bubble reflects the amount of research. So the more research we have, the bigger the bubble gets. And then on the other hand, on the bottom, you see some red bubbles, not many. And those are the research where we found evidence that it's not working. Don't do it, don't spend your time and energy on it. It might even be harmful. So again, good that we don't have a lot of red bubbles. And then you see a flurry of orange bubbles that are all the studies where it's promising, but we don't have enough evidence. The research methodology was not the strongest. Okay, so a word about research methodology and why we have so many orange bubbles. So again, historically, we often didn't identify what we're researching. And so a lot of the older studies don't hold the expectation and they get downrated. And that is also true, by the way, for a lot of medications that were on the market. Dr. Milo was mentioning the baclofen. I was astonished lately to do a review, and there are papers from the 70s. They're not at all anymore our standard of research, but nobody does a new research because we have the old research. So you get stuck in this limbo of not having necessarily the best level of evidence. We want to have research that is done with validated measures, and that's another thing that 20 years ago, 30 years ago, we didn't have a lot of measures for children with CP, And now many researchers across the world have added more and more functional methodology to actually give numbers to certain activities so we can quantify the before and after effect. Good research should include randomization, meaning that you take a group of patients, you offer them an intervention, but you have a control group, and you have an understanding of the natural history. So children with CP, very similar to your growth, follow very often a line. And the idea is when you have intervention, can we sway from that line? Can we actually jump a few points up? But for that, again, you need the measures to be able to be enough fine-tuning that. So those are all factors why research back then wasn't as good, but also now we're still often having difficulties. And the last point is really the most one that makes research in CP sometimes challenging, especially when it comes to therapies, is that in a perfect world, you want to blind people. And what does it mean when we say blind? When you get an intervention, we have a very strong placebo effect. We can heal people just by the wanting to be healed. That's great, and we sometimes take advantage of that. But we need to separate it when we really want to know the effect of, let's say, a pill. Now you can do placebo effect blinding, meaning that the patient doesn't know what they're getting, and you can do it also that the examiner doesn't know what the patient actually got when it's, for example, a pill. Even an injection, you can inject someone and have a control group and give them salt water, saline, which is innocent, and you can inject it and compare the results. But when you have an intervention that is hands-on, you can't blind. You know that the person did an intervention to you. So again, the methodology when it's not a pill is harder. And so again, a lot of the interventions that Dr. Novak published were in the yellow zone just because of that element. So it's really important to recognize when you see the yellow bubbles, it's still really good work, and not to dismiss it, but it's harder to get those green bubbles when it's not a medication study. So, because I showed you that we have so many studies that are now pouring out, when you research that in 2013, now we're 10 years later, it's half outdated. So Dr. Novak did a second round of re-looking at the evidence, and this is the paper in 2019. So many, many more bubble, and nicely to be seen, many more green bubbles. So again, people are consistently looking at how do we set up the research. Those bubbles are reflective of papers published from 2012 and onwards. And I will say she is not able to read 24,000 papers. So she is leaning here on papers that are actually doing review assessment, so meta-analysis, where other authors are taking a group of papers. So again, it's a wonderful reference paper, and even as a parent, I feel it has value, but it's a bit overwhelming to read. It's a lot, but it gives you the references then when you say, oh, I've heard about this intervention. What is she saying? Which references does she give? And then you can pop back there. So again, as a clinician, I use it widely, but I also recommend it to my families. So again, a little bit more about the actual take home from her paper and general principles of what would make you feel this is the good invention. And I will say, of course, as a parent, it's not you having to decide on it alone. It should be a team, but I want to also empower my families to really say, you have a say. And again, going back into the ICF, the family knows the child best. The child himself or herself should really be part of the discussion of what they want to achieve. So in medicine, we still strive for actual prevention, not to just fix when it's happening. So we do have good evidence, especially when it comes around prematurity, perinatal risks, which is about 50% of our children that have CP had those perinatal factors. So use of antenatal prevention to lower the risk of prematurity has made a huge impact on the numbers of CP. And also the neonatal cooling for children that are born with neonatal encephalopathy have a big change in the outcomes. So then going into the principles of intervention. And I wanted, again, as the neurologist, I need to tell you a little bit more in detail about what are the options up here to really have a change. And many of you probably have heard the term neuroplasticity. It means that our brain can still change. And we always talk about that you have better neuroplasticity as a child. But why is that? So children are born with actually the full amount of neurons. Neurons are our nerve cells. But what is not yet established, what is still forming, is the connection between those nerve cells. And it's called the synapses. And so over the first few years, we don't have an exact timeline where it stops, but I plus or minus would tell you it's about the first 5-6 years where those synaptic connections happen, and you have a lot of them. And I like to compare it to a city that lays out roads to get from point A to point B, and you're driving, and each day you're taking another road because you're not so sure what's the best way. And so it takes you time. But over time, you're figuring it out, oh, I think this street is working, and you remember it the next day, but then there's another day you don't remember again, and then back and forth. But over time, you have years in the making, you actually remember, and you're creating actually a highway. And so once you've established the highway, to maintain all those little roads is very costly and it's not efficient. So now you're, as a city planner, you're deciding to actually cut down on some of those side roads, they're not needed. And that is in the world of neuroplasticity called the pruning, similar like the pruning of a tree. So we have all these roads, and when you're born, you have an abundance of those potential roads, and that really allows the little children to have better outcomes than the comparable adult. Another analogy that I like to also explain to parents is when you have a field and you haven't put the seeds in, right? It's barren. And if you're an adult who had a stroke, your field, you had a forest there with beautiful trees, and now it's gone. And yes, you can replant it to some extent, but it will take you a long time. And as an adult, it is hard to go back. But the child that has the barren land, it's all fresh. You can still seed and grow. So that principle is what we often see, and I'll get back to that in a moment. So I want to walk you through a few more general principles of what makes a good intervention. And so when you get offered interventions, think yourself through, does it follow those principles or not? And that might help you inform what's working. So we know that of utmost importance is actually picking the right goals. What is it that we are trying to accomplish? We're trying to stay away from just lifelong do physio. That's too vague. We need to really understand what is it that we want to bring this patient to. We know that the effectiveness is better when it's very task specific, and we often see carryover. So you do one specific task and you might say, oh, is that really important that I'm working on that? But we know, and that ties into the neuroplasticity, that when you do things in an active way, you do it, that's when you train your brain. It's actually what also typical developing children do. It's when they practice and practice and practice. You know, little children like to walk on the sideways and to balance, right? And it gives the feedback to your body. You need that loop back and forth, so that it trains. So task specific is really important. Again, include in your goal setting the personal and environmental factors, and use the GMFCS to guide your principles. So again, we don't want to encourage, I hate when we say, oh, your child will never do X, Y, Z. But we do know that a child in level 5 most likely is not going to be an independent worker. So it is really important to use your energy for the activities that are meaningful and realistic, so that you're actually not getting frustrated because it's not happening what you put as a goal. So the GMFCS is a big one to help in the discussion, and that's why I emphasized earlier, if nobody has ever talked to you about your child's functional level, try it yourself. You can read, I do it always. I never come in to tell the parents, this is your GMFCS. I actually let them read the descriptors, and we together make the decision. And again, research has proven that parents are spot on. They know their child. General principle, the interventions will have more effect on neuroplasticity and outcomes when the movement is actually active. So, like in the picture, you give the child a toy in front of them and they need to do this reaching out. It trains their eye, vision, coordination, the amount of power they have to invest, and that gives for better intervention. It doesn't mean that a passive movement as part of it is wrong. We sometimes need to do stretching to still maintain ranges, but when we have functional goals and we want to get better, the active is much more better, and we have also functional MRI to support that. That makes the huge difference. Going back to the F words, one of the F words is fun, and I really want to highlight having fun embedded into your therapy is important. I have so often parents, especially when the children are very young, where the parents come back to me and we review what the child is doing, and they're telling, oh, this one, I don't believe it's actually the right one. I come to the therapist and they're only playing with my child. They're not doing therapy. There's really this notion of therapy is expected to be hard work, sweat, and maybe even tears and painful. No. Absolutely no. A child will not want to participate if it's all of these negatives, and our outcomes, our sustainability, that they want to participate is much better when it's fun, and all the efforts. If it's embedded with friends and family, we know that often group therapy is highly motivating because you're finally meeting also peers that have the same, and you're not going around your life thinking you're the only one that is like that. Of course, we often do combine interventions. So again, that is one thing that the traffic light paper of Dr. Novak really horns into specific intervention, but in the end of the day, we actually combine, and we should combine. So it's really important that it's rarely a standalone one fits all, and even just one. So just to give you an example, one of my patients who is a GMFCS level 2, he has sort of a triplegic pattern. He's actually non-verbal. He's very communicative. He can actually read and write, but he just cannot really talk. And he loves sledge hockey. So he came to us because his one arm is so much in a contracted posture that when he's trying to move himself, the sledge hockey just goes in circles, right? And it frustrates him. So he came in with a specific want. He's now 16, that he wants to improve his activity level, and what can we do? So our OT sat down with him, and he actually had already done some Googling, and he found that he might need a different device so that he could hold the stick, the sledge hockey stick in the hand. My OT set up a whole program. It took a long time to order the right devices, but we also decided that this is now the right time to also support him with medical intervention, including Botox. And off he went and really had some nice results. And then again, I spoke about it before. This was a very specific intervention with one specific goal, but we do have carryover. So now he's also better in actually other bimanual activities because the hand has been practicing more and got actually stronger and more controlled. So another word that I just mentioned is sustainability. And again, because it's a lifelong journey, you really need to pick your interventions. When do you want to invest how much time and potentially money? Again, a lot of their services hopefully are public, but we all come from different areas in the world. Sometimes we have more services public and sometimes less. And parents go around often with the feeling of, I don't want to miss the boat. Many have heard about early interventions. They want to front load. So sustainability is a big topic, and I always like to, again, share with my patients that if I would go to the gym every day for 2 to 4 hours, I can promise you my body would look different, probably more toned and stronger muscles, but it's not sustainable. It doesn't fit into my life. And so again, getting this approval and the discussion around what's worth it, because yes, we can do intensive therapy and get you to a different place. We can prove it in a paper that your muscle has become stronger, but how much is that needed and how much is it going to be sustainable? But I also will say on the other side, sometimes doing a block therapy, like a boot camp, can also be good. So again, I don't want to tell you don't ever do something that is not sustainable, because these little sprints in between have a place. But on the long run, be aware that you need to pick things that are sustainable. And home programming is really an important aspect, and actually in the green bubbles of Dr. Novak's paper has a lot of evidence that even if you have a great therapist and you go there once a week, twice a week, even 3 times a week, it's not the same as doing something that you can implement and goes back. Is it fun? Because if it's not fun, you won't do it as a home program. And again, I do like to talk to parents really about the financial aspect, and I remind them it is a lifelong journey, so don't go broke. Make sure to discuss it with other healthcare providers, that you're not getting caught up in promises, because that's what we sometimes see, that you get promised by private providers, do this and this, it's very costly, and people are telling me, I don't want to regret it in 10 years that I didn't. So again, that's where the professionals hopefully can help you guide, filter out what's worth it and what's not. So again, a little bit jump back to the associated problems, because again, when we talk about treatment of CP, it's the one arm is the motor, the core symptoms, but then all the others, and they are really important for your general health. They might be the source of your pain and your discomfort as well. So we have some very clear pathways that we know now, and they're often linked to your GMCS level, like the hip surveillance. We know that feeding and growth is really important for your general health, and hopefully all of our patients are linked to a good pediatrician that can monitor that. Bone health is a big one, and again, those 3 are all also, we have now really nice pathways that you can read up on the AACPD pathway website. And then other things that we have less good pathways, but we also know that we should monitor them is vision, hearing, cognition, and emotion. But that is a little bit more vague, who takes the lead and when. Early intervention, again, I won't spend too much time because I'm running out soon and I want to leave some question time, but I will say again, with my introduction about neuroplasticity, it makes sense that we are front-loading, that we're trying to do things a little bit earlier. There is a big push for early diagnosis. We are still sitting often at a diagnosis age of 2 and 3 and even later to even establish. In many places, in Ontario, for example, we can offer treatments without a diagnosis, but in other places in the world, diagnosis is the key of getting funding. And we do have tools to, at least the kids that have at risk when they had a perinatal event, where we know there's a high chance that they will turn into CP, we have the right tools to actually establish a diagnosis even around age 6 months. And then when we look at what are the interventions that we offer for early intervention, it goes back to the same principle, the active. Even babies as young as 6 months are starting to be interested in toys, and that's when you want to catch them. And you have a window where you can, for example, constrain their better arm, and they're not yet as upset, and they're trying hard with the less, but you hit the age of 2, and it's a time where they don't like it. And then you have another window that opens back up, and you have constraint use that are really effective even at an older age. So again, I want to emphasize that despite now the push for early intervention, neuroplasticity continues. So please don't be upset, especially when you have now an older child and you go back and you think, oh God, I missed that boat. Unfortunately, I was one of those who didn't get the diagnosis. It's never too late. Children's brain have plasticity beyond the age 5, and we really see good outcomes. So I'll end with that last slide with a few recommendations for websites. So the very first one is a website where all of us, when we do clinical trials, which are interventions and medications, publish. It's called clinicaltrials.gov. And even as a parent, you can enter, you give in search items, and then it will give you where in the world they're doing a special trial with, for example, a medication, and sometimes it's open. I will warn you, it's overwhelming, and doing a trial doesn't always mean that we have the evidence that it's working. So I would highly recommend when you find those, bring it back to your healthcare providers and discuss it. And I find it very stimulating when a parent like Manda is coming with a, what do you think about that? But that keeps us on the toes. And then there are other websites, and I picked only a few, but very good ones that really give parents and healthcare providers, it's for both sides, information about what's out there, and they really help with the knowledge translation. So with that, I will thank you, and I will be happy to take questions. Yes. I asked before this talk if actually my slides get shared. I'm happy to share slides. Yeah.
I also just wanted to say, so one of my missions at this conference was finding Dr. Iona Novak. So she said that she was going to start working on the next traffic light next year. So hopefully within the next year or so, she'll have even a newer version of the traffic lights.
Any other questions?
Please hold on 1 second.
1 second.
It won't be captioned or records if you don't talk into the mic.
So level 5, Botox, so relatively short-term use of the Botox, would that have long-term positive effects physically, if that?
So generally speaking, even so, Botox has a green bubble that is really big because we have lots of papers on Botox, but it does, the evidence is for short term. We don't really have long-term evidence, so you can repeat it, and we have lots of parents that feel there is value, especially for caregiving and well-being. I have patients that for 10 years I'm injecting again and again, and my principle is to ask the patients and the family, does it work for you? I don't see a lot of objective measuring changes, but the feel, and verbal kids with a level 4 and 5 will often say, I feel better. My limb feels looser, I like the feeling. Right. But yeah, we don't have long-term evidence that we are producing a progressive improvement. It comes and goes, and we have to re-inject.
Okay. Yeah, appreciate it. Thanks. Yeah, I'm just wondering if the practice with the Botox, if that practice would lead to long-term effects. But again, you don't have the evidence for that would necessarily
and again,
be the case.
Children that respond to Botox when it's going on, in many institutions, the decision will then be to not continue the Botox, but to actually then do an orthopedic surgery and have then the long-term effect.
I see, okay.
Yeah.
Okay, great, thanks.
Any other questions? Yes.
How do you counsel families who, and I feel like a lot of this stuff is on right now on Instagram and Twitter and these images of these places where families are going and spending a lot of money, and they are passive, and the things are being done to the baby. Even looking at like hyperbaric or some of these things that we know are red lights, or potentially below the dotted line, yellow lights don't have enough evidence, and also kind of don't meet those criteria. They're not task specific. They're not. They're passive. They might not have applications or practical goals associated with them, but the family's potentially thinking, this is what I'm seeing on Instagram. This is the hot new thing. How do you counsel families about how to make a decision around that?
I thought I had another version and I had another slide to show you, but I think that's where the discussion of natural history comes in. And it makes also the research harder, but we do have an understanding of the trajectories. So again, my discussion always starts about this is a child, children develop. They're not standing in the same point. So I try to get them to understand that while they're going to an intervention, they will see often, regardless, an improvement, because that's what we're expecting the child. Walking them through more or less what I did today with you is what I do in my counseling. Some parents, it will make them take a decision to say, therefore, I don't invest, and others will still say, I need to do it. And again, even if I am convinced that a specific intervention isn't as necessary and it's very costly, but I will tell you anecdotally, parents come back from these trips. It's like going to summer camp, and sometimes they go as a family and they come back and they really enjoyed it. And I go back to my efforts philosophy. In the end of the day, I want the child and the family to enjoy. And I might say you might not need a very costly, but if that's where you find your friends, and you find you connect with families that have similar issues, I think that is worth as well. So again, I had families who over time recognized that they actually change their goals. They're not anymore thinking about making the child in level 5 a walker, but they still like it. And then by all means, if you can afford it, go, but it takes away maybe the pressure to do it out of a guilt, right? But yeah, in the end, I feel like we can only be there to help support parents' decisions. Who am I to make the final decision? And I don't like to, I think with getting older and older, this idea of I know it and you have to do what I'm telling you, no, that's not right. It's a joint discussion, and hopefully it can be informative. Yeah. Okay.
Well, thank you, Dr. Mesterman, for taking the time to join us and for the great intervention information.
Before we have our next panel,